Good afternoon to all of you, and thank you for joining my colleagues and I from the Council of State Governments for this webinar. Our goal is with this webinar is to help all of our participants get an understanding of some of the key trends and developments around Medicaid, and also to help provide you with tools and ideas to advance policy and legislative oversight in your respective capitals. As you know, Medicaid is a critical public health insurance program in all of our states. As we'll hear in a little bit, many individuals in our states rely on Medicaid for their health insurance coverage. Also, according to the National Association of State Budget Officers, in fiscal year 2023, Medicaid accounted for nearly 30% of total state spending and 18% of states' general fund spending. For this webinar, we're very grateful to have two terrific experts and presenters to help us through, Robin Rudowitz and Ben Eike. We'll hear from them in just a moment, but quickly, I just want to go through a few reminders. First, the webinar is being recorded, and we're doing that so that it will be available for you and others who have asked to watch it after the webinar is over. A recording will be made available very shortly on our CSG Midwest website, and we'll also send the recording and slides to all participants. Second, just to make sure you're aware, there will be time after each presentation for questions from you. So we hope this can be an interactive session for the next hour. Third, I just want to note that this webinar is part of CSG's ongoing work on health policy. And that includes our support of the Midwestern Legislative Conference Health and Human Services Committee, which organized this event. That committee is a bipartisan group of legislators from across the Midwest and is led by the three legislators that you see here on our screen: Kansas Representative Susan Concanon, Illinois Senator Julie Morrison, and South Dakota Representative Taylor Rayfeld. So, of course, at CSG, we very much appreciate their leadership on health policy in the Midwestern region. Second, my name is Tim Anderson. You see my picture there below, and I serve as the lead staff person for this MLC Health and Human Services Committee. My CSG colleague, Sean Sloan, also is working on several health policy related projects at the national level of CSG. And I wanted to make sure and recognize Sean and give him the chance, if he's on here, to let you know about some of the work that's being done by CSG and about some potential opportunities for you. Sean, are you here? And if so, can we unmute Sean so he can speak a little bit about some of the work going on at CSG and some of the opportunities? There you are, Sean.
Can you hear me?
I can, Sean.
Thanks so much, Tim, and hi, everybody, and season's greetings from CSG headquarters in Lexington. I am Sean Sloan. I'm a senior policy analyst at CSG, and in that role, one of the things that I'm responsible for is putting together the agendas for our Medicaid Policy Academies that we do every year in the DC area. Today's presenters, Robin and Ben, are both veterans of those academies, and they joined us back in September as we successfully pulled off two academies back to back. One, a Medicaid 101 program for more recently elected state officials that we try to do every other year, and the other, our Medicaid Leadership Academy, that is an annual event for experienced committee chairs and others. Ben led a great workshop on legislative oversight of state Medicaid programs, and Robin drilled down for us on the great unwinding of 2023, as it's become known, and also enlisted some of her KFF colleagues who provided valuable expertise on things like 1115 waivers, behavioral health, and individuals with complex health needs. I'm looking forward to hearing them continue the conversations from September today and look ahead to what might be on the horizon in 2024. So we thank them for sharing their knowledge. While we have not yet announced dates for our 2024 Medicaid Academy, I hope we'll be able to count on their participation for future events. If you'd like us to add your name to the list of policymaker invitees for a future academy, please reach out to Tim or myself. The other thing I wanted to mention is that in addition to our work on Medicaid policy, I am also leading a project for which CSG has received support from the Commonwealth Fund that is helping states address the needs of the long-term care workforce. something that I know has been a concern across the country. We are hoping to bring some programming to the states early next year as legislatures convene for the 2024 sessions. That can take the form of technical assistance from us and facilitated action planning on long-term care workforce solutions. Or if your state is not quite there yet, we can help you explore what you might want to work on in the future and kickstart the conversation on these issues. If you're interested in having us come visit during session, please reach out. We have a new website on long-term care workforce policy on which you can check out our policy guide, view recordings of the 8 webinars that we did this year on everything from the dementia care workforce to expanding career pathways for certified nursing assistants. Sign up to join our network and request technical assistance from CSG. I'm going to add the URL in the chat, and I encourage you to check that out. Thanks to Tim, thanks to Robin and Ben, and thanks everybody for joining us today.
Sean, thank you. And I do just want to emphasize, Sean's doing some really great work on issues, of course, on Medicaid, but as you mentioned about the long-term care, and we really hope that you take advantage of that and advance some of these policies in your states. And again, thank you so much to our 2 presenters, Robin Rudowitz and Ben Ike. We feel really fortunate to have both of them with us, and we really appreciate the time they put into developing the presentation. So we're going to turn this over to Robin here. First, we'll first hear from Robin Rudowitz, who is really one of the nation's foremost experts on Medicaid. Robin is the vice president at KFF, which is an indispensable independent source for information on health policy. KFF is an amazing resource that I use all the time, and I'm sure that you all do too. It's just as I said, indispensable. Robin serves as the director of KFF's program on Medicaid and the uninsured. And in this position, Robin oversees KFF's work and research on Medicaid, the Children's Health Insurance Program, and low-income populations in areas such as coverage, eligibility, financing, delivery systems, access, and long-term services and supports. So Robin, I thank you very much first for the terrific work you do at KFF, and then I thank you too for joining us today.
Great. It is a pleasure to be here, and thank you for inviting me, and I'm glad that Sean is here, and I really enjoy participating in the Medicaid programming that you usually do in the DC area. As Tim said, KFF has a lot of resources, so I'll just put in a plug for kff.org. So I'm only going to be able to touch on a few high-level issues today, but we have a lot of state-level information as well as, information on many of these more in-depth information on many of the issues that I'll touch on today. I know that it is a busy time as gearing up for the holidays as well as state legislative sessions, but Medicaid is a really complex program, so I appreciate everyone taking time to hear what's on the horizon from my perspective, and we will sort of jump in. I wanted to provide 3 key slides that Sean, I'm sure, has seen before, so you can go to the next slide, that sort of just do a little bit of level setting on the Medicaid program and highlight a few key issues before we dive into the key issues that might be at play for 2024. So this slide just really shows that, of course, as I mentioned, Medicaid is a pretty complex program, but it also has really a lot of roles, multiple roles in the healthcare system. So as we know, it's affordable, comprehensive coverage for about 1 in 5 Americans across the country. But it also has some other roles that I think get a little bit less attention. Medicaid is the program that helps the Medicare program work for low-income Medicare beneficiaries. It provides both wraparound services as well as help paying premiums and cost sharing for more than 12 million low-income Medicare beneficiaries. One of those key wraparound services is long-term services and supports. It's Medicaid, not Medicare, that is the primary payer and provider for long-term services and supports in this country. So Medicaid is a huge player in that role. Medicaid also represents $1 in $6 that's spent on healthcare in this country and is a particularly important revenue revenue source for the healthcare safety net system, so clinics as well as safety net hospitals. And of course, unlike really any other program in state budgets, Medicaid, as was mentioned, has a pretty complicated role in state budgets because it's a big spending item, but it is also the largest source of federal revenues that's coming into states. So next slide. So since it was enacted in 1965 alongside with the Medicare program, there are sort of these fundamental key elements of the Medicaid program that remain to this day. It's an entitlement to individuals who are eligible for the program, but it's also an entitlement to states to get those federal matching dollars with no cap. And it's also a partnership between the federal government and the states. So the federal government sets these broad federal requirements, and then, you know, I'm sure people might have heard this expression many times before. If you've seen one Medicaid program, you've seen one Medicaid program, because all states really administer their programs within those broad federal rules in different ways. So all Medicaid programs are different. Next slide. And then I think the next slide. Yeah, so then the next sort of level setting is related to enrollees and expenditures. And I just also always think it's an important reminder to show the share of enrollees across different groups and expenditures. So kids and adults make up the large share of enrollees who are on the Medicaid program. In fact, kids, Medicaid provides coverage for about nearly half of all kids in the country right now between Medicaid and CHIP. But they represent a much smaller share of expenditures. So Medicaid provides a lot of coverage for people with disabilities and seniors. And those individuals use a lot more complex, both acute care and long-term services and supports. So expenditures for those groups are disproportionate to their enrollment. So next slide. So I think with that as context, I wanted to jump in and highlight just a few key issues that I think I'm certainly watching in 2024. And I put them in sort of these 4 buckets, but coverage and financing, of which the unwinding is certainly the dominant policy issue. Access, which has a number of different components, and I'll touch on a few of them. LTSS, and I'm glad that CSG is going to be doing some more work in that area, and certainly workforce and reimbursement rates are key in LTSS. And then, of course, there are some external factors that have implications for the Medicaid program. So that's sort of our roadmap, and then I'll dive in to a little bit deeper to some of those issues. Next slide. So I think everyone has probably heard of this great Medicaid unwinding, but certainly during the pandemic, there were policies put in place to provide continuous coverage for Medicaid enrollees, as well as provide states with enhanced matching dollars for that coverage. As a result, when we look at enrollment from February 2020, so the month before the pandemic, to March 2023, we see that enrollment reached over 90 million people. It was a 32% increase from prior to the pandemic, and this continuous enrollment policy was a main driver of that. This provision was originally tied to the public health emergency, but as a result of the Consolidated Appropriation Act that was passed at the end of 2022, this provision ended on March 31st, and states have begun the process of unwinding or doing redeterminations for all individuals who are on the Medicaid program. At the same time, the federal matching funds for this will phase out through the end of next year. So we've already seen some declines in enrollment. There's federal data through August 2023. So we've already seen a 5% decline from from the end of this continuous enrollment provision. KFF has a pretty elaborate unwinding tracker, and we've been tracking both state by state and federal data, and that is available on our website. Next slide. So where are we now? So across all states, there have been renewal outcomes for about 1/3 of the people on the program. So that means there's still a lot of people that still need to go through the renewal process. And what we see is that close to 12 million people have been disenrolled. About double that number have been re-enrolled in coverage. And then there are a number of applications that are still pending in the states. So we are watching this quite carefully and trying to, we won't know what happens to individuals who are disenrolled. We know that some of them might re-enroll in the program, a process called churn. Some of them might transition to other coverage, and then a number of others might become uninsured. So we will certainly be following a lot of what's happening. Next slide. We do a survey of all the states, and we usually put out a report that looks at enrollment and spending, as well as various policy issues that we put out in the fall. So this data comes from that spending and enrollment report. And when we asked states over last summer what they thought was going to, be part of their 2024 state fiscal year for spending and enrollment, states did anticipate across all states declines in enrollment as the unwinding unfolds. And because enrollment, and you could see these trends going back quite a bit, enrollment is the largest driver of changes in spending. So when you see when you see enrollment going down, that is going to pull down overall spending on the Medicaid program. If you go to the next slide, though, we know that, again, Medicaid is a shared program in terms of financing between states and the federal government. Usually spending for states and the federal government move in tandem. But there are some instances where there are changes in that match rate, where there are changes in state and federal spending trends. So we saw that because of the enhanced match, so states were getting more money from the federal government, state spending actually declined, even though enrollment was really peaking and growing very quickly because of that enhanced match. But we know that when the match rate switches back and as this match rate phases out, that states will then pick up the normal share of their Medicaid program spending, and that will cause this shift, so increases in Medicaid spending. So that is certainly an issue that's on the mind of many states. Looking forward to next sessions. Next slide. So we could spend an entire session certainly on unwinding, but I wanted to touch on the next big bucket of items, which is related to access. And access really encompasses a lot of different pieces. It's how services are delivered. It's what benefits are covered, how much is paid for those services, all affect access to the program. So we have a lot of detail on many of those pieces that are part of this annual survey that I mentioned. And I urge you to take a look at that survey, but I'm going to pull out just a few key findings from that report that I see are issues to watch related to access. So next slide. So each year states make decisions about benefits. So what's going to be covered, certainly during economic downturns, sometimes states trim back on benefits, and at other times to try to address priorities or meet other budgetary constraints, expand services. For the last several years, we've seen states really prioritizing expansions in coverage for mental health and substance use disorder services. So over a number of years, states consistently have been making expansions in that area. Of course, it's become a large priority. And again, we have information. Some other key areas of service expansions relate to pregnancy and postpartum care, preventive services, and I feel like dental is always an optional benefit for states that's on goes up and down, but more states are adding some more dental services. Next slide. When we think about addressing behavioral health, benefits is really one piece of expanding access, similar to issues with LTSS that we can talk about. There are shortages in terms of behavioral health workforce. We did a special survey looking more in detail at what's happening with behavioral health. And states were really implementing a range of strategies to try to increase access and expand the workforce. And those spanned issues like increasing rates, reducing the burden, the administrative burden for providers to participate, extending the workforce, so looking at other mid-level practitioners, and incentivizing participation for providers to participate. So we'll continue to see how that evolves in the behavioral health space as demand for a lot of those services continues to grow. Next slide. Another key area that we're paying particular attention to is around social determinants of health. So for many years, Medicaid, of course, cannot pay directly in most cases for many of these services, but states have been pretty innovative in trying to leverage Medicaid to help refer and help address some issues related to social determinants of health. More recently, the federal government has put out additional guidance related to how states can use Medicaid to address health-related social needs and social determinants of health through special 1115 waivers, as well as through managed care. So a number of states are continuing to evolve and take up some of these new options and flexibilities. Next slide. Some of the early states to adopt some additional programming to address social determinants of health after the guidance came out are Arizona, Massachusetts, and Oregon. And there's a range of services that are pretty, outlined more specifically in the guidance that these states are taking up, particularly related to housing and nutrition. So again, not going to cover each and every item on here, but we have a lot of, we are watching to see what states, given that this guidance is fairly recent, take advantage of some of these options related to the new guidance. Next slide. And then I think the last bucket is I wanted to touch on is related to long-term services and supports. Again, Medicaid is the largest payer for both nursing facility as well as home and community-based services. There are about 6 million people who use long-term services and supports. Most of those individuals are getting home and community-based services, but of course there's a lot of variation across states in that distribution of institutional and community-based services, and that depends on, again, most of those home and community-based services are either through waivers or they're optional. So states, again, have a lot of flexibility in how they're delivering those services and who's covered. Next slide. We also know that there have been really challenging issues related to workforce for the long-term services and supports. So while there was dips in healthcare employment during the pandemic, a lot of that employment has bounced back, but we can see that employment for LTSS still remains below levels that were from before the pandemic. So it's a challenge. Demand is increasing, population is aging, Medicaid is the biggest payer for these services, and the workforce is still lagging. Next slide. One thing, again, that we picked up on our survey is that, again, one way that states are trying to address some of these workforce challenges is through looking at reimbursement rates. And we do see that nursing facility and HCBS providers have received, or states are paying more attention to increasing rates and also doing rate reviews for those providers relative to other providers. Next slide. So with that, I just sort of want to wrap up because that was a lot in a short period of time, and I really look forward to questions, because again, any of these topics we could spend a full hour or more on. But I wanted to even highlight a broader view of things that we're watching. I mean, we've already talked about some of the issues around unwinding. So I think that sort of is underpinning everything that's going on for states, both with eligibility, fiscally, it affects everything related to what's happening in Medicaid. But beyond that, I think states were really focused on workforce. I mentioned both for behavioral health and long-term services and supports primarily, and also really expanding access in those areas. There's still a lot of attention. I feel like it's gotten a little bit lower level of attention on delivery system reform. So things like value-based payments, some of that is still ongoing related to prescription drugs. States are doing a close look at provider reimbursement rates. So again, more so than in other years, states were increasing rates for primary care and doing these rate reviews that I think we haven't seen in a while. But all that said, there's a little bit of an uncertain fiscal outlook. So certainly what happens more macroeconomic forecasting in terms of state revenues and broader economic indicators are going to have a big effect on what states can do with regard to, expansions and in many areas. So we'll be watching all of those things. And of course, this will also spill over into an election year, both, at the federal and state levels, of course. So election years always are things to watch because elections matter for policymaking, particularly for states and addressing issues at the Medicaid level. So I will wrap up there. I think I had maybe a minute to spare my 20 minutes, but I'm happy to answer. Are we going to take questions now or?
Yeah.
Great.
Yeah, Robin, let's take some questions now. I see that there's some questions, or there were some questions that put in the chat, and I see a few hands raised here. Let me just get quickly to the questions that were asked directly of us while you're presenting. Let me go to figure 19 here, where you showed kind of the state-by-state look at long-term care services. And the question involved, it looked on this, and you can see here, there looks to be considerable variation in terms of institutional care versus home and community-based services. Can you explain a little bit the question regarding this kind of significant variation? And does this reflect big differences in how care is delivered in these states, or is there something else in this figure that we should know?
Well, yeah, I think it's been a big focus. I mean, there is an underlying bias for institutional care in the Medicaid program because nursing facilities is a mandatory service, whereas a lot of home and community-based services are optional for states to deliver. So starting many years ago, there's been a focus on, I think it's often called rebalancing, but it is more so balancing the delivery of care from institutional care to more home and community-based settings, which individuals generally prefer, but the availability of both workforce and providers and the availability of these services has implications for how much care is delivered in a nursing home versus in the community setting.
Okay. And then just one last thing that we were asked, and then we'll open it up again. You mentioned several times about the changes states are making, increases to the rates to the providers. Has KFF track like the differences in how states pay their providers in terms of the rates? Is there significant variation in one state to the next, and how much those rates are?
Yeah, so that's a great question, but it's really hard to get at. And I would say one of the primary reasons it's hard to get at is because a lot of care in Medicaid is delivered through managed care plans. So all of those rates are proprietary. So we do ask on our survey, what is happening, the directionality of rates, which services are getting the most increase and potentially the level of those increases. But understanding the base rate is pretty difficult. We did ask some questions about that on our home and community-based services survey to states. And it was pretty difficult for states to report some of the rate information. We did put out what we were able to get. But I think it's something to continue to watch, because there have been some proposed regulations to increase some of the transparency and pricing. So I think we're going to have to watch to see if those data become a little bit more available. We still ask about the directionality in fee-for-service, because we do know that for managed care, many states still use fee-for-service as a base and use that directionality to apply to managed care. But again, because of the managed care penetration, so it's about 3/4 of or 7 in 10 people on the program are in managed care. So it is very difficult to get at what the actual rates are to providers in Medicaid.
That's great, Robin. Thank you. Senator Mathern, I know you have a question. You have your hand raised. Senator Mathern, would you like to chime in here? Thank you for joining us too.
Yes, thank you, Robin. In light of the fact that there's been a waiver process in place for about 10 years now regarding the IMD, Institutes for Mental Disease, and a lot of states have been doing waivers, is there any possibility that this will just be standardized and we'll have a new policy regarding IMDs in Medicaid and their reimbursement?
So I don't know the broad answer to that question, but certainly the issue of the IMD exclusion is one of those issues that's currently being debated in Congress as it relates to the Support Act and the IMD exclusion for mental health and substance use services. So that was a state option. Very few states had taken it as a state option, but it was time limited, so it expires as a state option. So Congress is currently debating that right now about whether they should extend that as a state option for those services as part of the reauthorization of the Support Act right now.
Well, what's your guess? What's going to happen?
Well, it was in place. Again, not that many states have taken up the state option. And it is available for states through the waiver process, but where, as you mentioned, many more states have done that through the waiver process. I think there's a little bit more negotiation about ensuring that IMD services are part of a broader continuum of care and not, substituting financing for things that some states are already doing. But yeah, it has been an exclusion for, I think, since the beginning of the Medicaid program. And again, there's been a path through waivers and a more narrow path through state plan that is currently being debated.
Are there any other questions right now for Robin? Okay, Robin, that was such a great presentation. Thank you so much.
Wait, I have a question.
Yes. Is this Illinois Representative Robin Gable?
It is.
How are you?
I'm good. How are you, Tim?
Good.
So, just a couple questions. That was a great overview. And of course, you spoke very quickly. You had to cover a lot of information in a short period of time, but I really appreciate it. So I just focused a little bit on the two health-related social needs that are, I see that at least 3 states are taking up. I thought that Illinois, maybe we didn't get approved yet, but I know that we put in.
Yeah, no, this was just highlighting the 3 states that were the first that were approved after the new guidance was in place. There are a number of states, and we have I'll put it in the chat, our once I switch off, our waiver tracker, and we actually have now updated the waiver tracker. So we're trying to do a better job of tracking what's happening at states regarding this issue. So I have to go back and double check what we have, because a number of states have had things in the past, or now applying for amendments, and given that the new guidance is out, but I will definitely put that in the chat. And there are many more states. I just highlighted those 3 because they were the first after the change in the guidance.
Okay. And it seems like federal government is pretty receptive to approving these. Is that
Well, yeah, so basically, I think there were states doing a lot of different things. So I think there's now been 3 sets of elaborate guidance, how states can address this through managed care and using something called in lieu of services. So, again, elaborate guidance of how states can make this as part of their capitation payments and what are the requirements to do that, sort of the parameters about how states can think. So it sort of speeds the approval process if, you comply with, this is sort of the framework to do it through 1115 waivers. So, and then there's been guidance on both of those, and I'll put some other resources related to both of those things in the chat.
Good. So it sounds like it gives you a path for how to get approval,
Yes.
which they will approve and which they won't. Well, that's good to know. And then on maternal health, I saw that you thought that would be increased as well. Did you have any ideas of how? Like what were states going to be doing to improve maternal health?
Yeah, and again, I can post some more of the details from our survey. There have been attention on rates, but there's also been extension of services, so particular services for individuals, or expanded benefit packages for pregnant and postpartum women, whether they're related to mental health or behavioral health services or dental, and expanding the workforce also, so coverage of things like community health workers and doulas, and those are issues that both expand access and try to address some culturally competent care, and increase access across and increase equity, or address other health disparities, particularly for maternal health. But I'll put all of those or a few of those issues in the chat, and then certainly happy to follow up with other
research. And they're in the KFF report.
Yes, so I can send you the full report, and that section that breaks out some of what's happening on maternal health, and then I'll send you some of the waiver SVOH information as well.
And I can also just get it on their website, KFF.
Yeah, although our website is a little bit of a bear, I'll have to say. I think we're undergoing some changes that are going to make things, but when I know that things are there, sometimes find our our search function a little challenging.
Okay, great. And does KFF stand for Kellogg? Is Kellogg? No?
So we now fully go by KFF. We originally were the Kaiser Family Foundation, but of course we are not at all affiliated with Kaiser Permanente. We have no family members on the board, and we are not actually a foundation. So we are trying to go by KFF because we are not what the other words mean.
Okay, great. Thank you. Thanks so much.
You're welcome.
Well, yeah, thank you, Representative Gable. So it's great questions. And Robin, I appreciate you sending that in the chat. And what we can do too is make sure everyone on this call gets some of the, we'll also email folks with some of those resources as well. So again, thanks so much for that presentation. Let's now turn to this important issue of legislative oversight. And to help us, we're going to turn to someone who's becoming an increasingly familiar face to us at the Council of State Governments because of the terrific work and programming that he's been providing to us at recent CSG meetings. Ben Ike serves as the manager of state training and communications. There's Ben, at the Levin Center for Oversight and Democracy. Housed at Wayne State University Law School, the center was established to carry on the legislative oversight legacy and public vision of U.S. Senator Carl Levin. Ben came to the center after work in the Michigan House of Representatives and the U.S. Congress. His goal with presentations like this one are to provide bipartisan, fact-based information on the tools and strategies that can be used to ensure effective legislative oversight of important programs such as Medicaid. Ben, thank you very much for being here and being such a great resource for CSG and the people we serve. And I'm going to go ahead now, Ben, and turn the screen over to you.
Thank you so much, Tim. Give me one moment so I can share my screen. And I think we are good to roll. Well, I'll start off by saying thanks again to Tim and to everybody at CSG, CSG Midwest, CSG in the headquarters in Lexington, CSG in the West. I mean, all across the country for being such a valuable partner as we've been able to grow at the Levin Center and at our State Oversight Academy. So as Tim mentioned, my name is Ben Ike, and I travel all across the country doing workshops on conducting state legislative oversight. And I actually just this week, I was in Delaware doing a workshop with their Joint Legislative Oversight and Sunset Committee. I really appreciate you all being here this afternoon. Just to give you a quick breakdown of the Levin Center, just a little more information. So we do those types of workshops. We've been in existence for almost 10 years now, and we've been doing these workshops with Capitol Hill staff for oversight, and then we grew into the states. We do big national webinars like this one. We do various presentations on certain specific topics, including Medicaid. We have a lot of research and reports published in 2019. We did a 50-state study where we discovered, we called them the 6 avenues of legislative oversight. I'll share that in a few slides. We also have our state legislative wiki, which has comprehensive information on the oversight structures and programs and processes all across the country in every state, territory, and the District of Columbia. And we use the information from that to create oversight overview videos, which I'll share because we do have one specific on Medicaid oversight committees. We have, if you need more information, I'm always available. I'm happy to talk with any of you anytime. benjamin.ike@wayne.edu. So this is kind of a breakdown of the agenda for a duration of our time here together. I'm going to walk through what we mean when we say what is legislative oversight, share a little bit about the wiki. Going to be talking a little bit about, once we've convinced all of you that you can do oversight, and oversight's a great thing to do for your legislature on Medicaid, well, how do you find the topics? How do you find different things? Oh, Medicaid is a big, just massive, kind of intimidating topic, and then finding areas that you can kind of do these inquiries and be able to get the information you're looking for. We have various best practices that we always share, different ways to be able to structure your legislature for success in oversight. And then we're going to talk about crafting a Medicaid oversight plan with the great leadership of Sean from CSG. Back in September, I was part of a presentation where we showed building this sort of a Medicaid oversight plan with a little bit of help from a professor friend of mine from Georgetown. And so we'll be able to walk through creating that type of a scenario together using this grid that's been developed here at the State Oversight Academy. So when we talk about what is legislative oversight, I really like this framing of it being the eyes and the voice of the people. This is from a relatively recent court case discussing how it's the proper duty of the representative body to look diligently into every affair of government and talk much about what it sees. It's meant to be the eyes and the voice, embody the wisdom and the will of its constituents. Medicaid is a great way to be able to apply your oversight authority in your state legislature. So this is a way we try to kind of just frame out what we're doing within legislatures. We think about the cycle of accountability, being the eye and the voice of the people. You have some sort of an issue that will pop up. Then you have your oversight of it. You find the facts on what's going on. What might not be working the way I want it to. You have the bill, becomes law. Regulation, we just continually go through this cycle, making things run better and better. Well, the problem that we are seeing all across the country, and it's no one's fault, it's just what we're seeing, is that we see problems that'll pop up and we all want to rush to a bill. We want to rush to a bill as fast as we can. And the issue of doing that is that a lot of times by doing the oversight, getting the information just a little bit more, we can enter up with a little bit more of an effective solution. And then we have that blue line in between the legislation and regulation, just as a way to be able to show how legislation does feed into the regulation process. I won't name the name, but I did know another state when I showed this red arrow to an oversight committee. I've never been more bashful in my life, because their entire committee gave me a round of applause for that red arrow, which I thought was quite the moment. So when I discuss oversight, this is kind of your classic political science language, thinking about routine oversight versus event-driven oversight. So event-driven is your firefighter. There's something in the news. There's something, really, a nasty report that's been published by a state auditor, perhaps, showing something that really needs urgent attention right away. So, things like scandals, disasters. Your routine is going to be things that you can use to deter malfeasance. So let's say maybe you're on an HHS appropriations committee and you really care about a certain aspect of Medicaid. Can you require certain reporting from the agency to be able to help to kind of keep things on track and let them know you're keeping an eye on this issue and you really prioritize it and want to keep things working the way they ought to be? So there's a lot of different ways to be able to structure your routine oversight and your event-driven. And I also just want to remind everybody that it's a really amazing thing to be in elected office. You have all these superpowers. Your legislator phone calls, your emails, they get returned. People want to equip the legislators with facts and information for decision-making. And you can have all of this capacity, all this leverage to be able to request investigations, request reports, get information needed to be able to decide what's working and what can be done better. It's a very special spot to be. And what's the best part about being in a legislature, at least my time when I was working in Michigan as staff, I loved the fact that I'm working with people from every community, every neighborhood, all across the state of Michigan. Where else does that happen? Like, I have my community, I have the people that are my neighbors, I have the people that I interact with on a regular basis, but I had a chance to be able to work with people from a very different walk of life who wanted the same things. And that was a really unique opportunity that legislatures, you have an opportunity to do that, but it's not true in a lot of other aspects of life. Seize that, use that. So in 2019, we published our 50-state study, and one of the best things that we learned from that study were these 6 avenues for state legislative oversight. So you have your analytic bureaucracies. This is going to be people like your state auditors, an ombuds office, maybe a comptroller general, inspector general, different offices like that, who are helping to equip the legislature with facts, information on what's working and what can be done better. Your appropriations process is where your oversight leverage is probably at its highest. It's that opportunity to be able to say, okay, you will receive your funding, but I want to report. I want to know how this is working, how that is working. I want it on a quarterly basis, maybe every 6 months. There's a lot of different ways to be able to get information through the appropriations process, pull somebody in for an appropriations hearing, which is kind of similar to oversight through committees, where you have your policy committees you can bring in, do great hearings. Here at the Levin Center, we've done master classes on asking great questions in oversight hearings in state legislatures across the country, and different ways to be able to structure, witness flow and all those different types of questions. Administrative rule review, lots of different ways we see oversight on this from all across the country. We have, sometimes administrative rule committees that are going through and looking at only at new rules or maybe only existing rules. In some states, there's authority in every policy committee to be able to review an administrative rule. Lots of different approaches. Advice and consent, if you have a new director or a new secretary coming in to run an agency, it's an opportunity to conduct oversight, get information about what's working, what can be done better, getting the facts as part of that confirmation hearing, typically in a state senate. And then the last one, this one's gained a lot of attention, mainly because of response to the pandemic, but also because of the increase in infrastructure spending, monitoring contracts, being able to think about from the word go, as we have all these new contracts that are being developed, how do we, from the front end, incorporate the oversight, getting the information to the legislature on what's working, what's on time, what's within budget, making sure there's authority, pull a contractor in for a hearing if things seem to be not going quite the way they should, how to prioritize those high risk, high dollar types of contracts that are in existence for Medicaid and for other programs. So I just wanted to share a quick screenshot, and I know we're running short on time, so I won't share the video, but this is a screenshot of our state legislative oversight wiki. And what I would welcome all of you to be able to have a chance to do on that, on our website page, we have featured reports and resources. And then inside of that, we have featured agency reports. And we have all of these different this table of contents, and we have a spot for healthcare and Medicaid related reports. So what I kept thinking about was how back in Michigan, there were topics that I cared an awful lot about, but just at that moment, there might not be a report published out of anything in Michigan on that topic. So what we've tried to do is develop a resource for all of you to be able to go and see if maybe New Hampshire has something out about it, maybe Iowa, maybe Minnesota. And you can go on there and be able to kind of get inspired on what you might be able to do in your own state. So if you take a look at that, I'd appreciate it. And if we have reports, if you have reports that you'd like to have us include, send them my way. I'll make sure to get them up there. So lots of different places you can have the origin of investigation topics. This is a big slide and I won't go over all this, I promise. But just thinking about different ways. I mean, even some of the slides that Robin shared could be really good examples of topic of an origin source. I mean, I really liked the one where she had kind of those 6 different blocks, looking at provider rates, managed care, benefits. That can be a start. That can be your inspiration of different topics and go, okay, now I want to drill a little bit deeper, find a subtopic within kind of those bigger topics within Medicaid, and then flip that into a question that I need answered. That's the kind of stuff that we really focus on here at Levin Center. I wanted to share, I mean, I know we're here talking about Medicaid, but oversight is very broad. There's a lot of topics that you can look at in the state legislature, from, you know, pension funds, foster care services, infrastructure. Just if you are choosing to walk the oversight path with Medicaid, you will not be alone with other different areas of policy happening all across the country. So when you're doing an investigation, this is coming straight from Capitol Hill, where you first kind of do the fact-finding procedures and get all the information you really need, and then develop it into some sort of written product. We have some committees that will develop reports and put them on their websites. They'll also do hearings. They'll get more information that way as well. And then there'll be follow-up 6 months from now if we have recommendations and things to be able to improve performance, being able to make sure that we really had some progress, that things moved forward, that it wasn't a hearing, everyone shrugged and said, well, that was really terrible. Oh, well, and then so what we want is 6 months from now to really see that positive impact that we know we can have. I like sharing South Carolina's committee as really one of the better examples all across the country, their oversight. They have 5 subcommittees within their full committee. They had a video archive. They have a public input form where you can go on their website. They have a staff. I'm really good friends with their chief, and you can actually type in, as just a citizen of South Carolina, what you think just deserves an inquiry, something you might not understand. Maybe they want to look at road funding, they want to look at Medicaid, whatever it might be. And that's been a really positive thing for them that they've been doing. And they have a full 7-year agency review as well. They do a transparency report to their citizens. Every transparency report since 2014, it's all available online on their website. It's just really good and one of the better structures we've seen across the country. Give a couple of examples of recommendations here. So Michigan, we had a joint resolution to create a joint oversight committee with balanced party membership. It's exactly the kind of thing that you could look at if you're trying to really enhance your oversight capacity in your state. And then a lot of other just good, like, general approaches and recommendations. So when you're thinking about oversight planning, anybody, you can do this at any structure. You can do this within a committee. You can do this within your caucus. We've held workshops with both. And we've been able to really be successful in helping people get together and think about, well, what should we prioritize? And then how do we go forward? One of the pieces of feedback that I got when we did this presentation in September back at CSG Medicaid was from a director of a Medicaid agency in a state who asked me to include a slide on civility, because they were, I mean, just the personnel that was interacting with the legislature just felt like they were being, really belittled and really attacked for things that just simply weren't their fault. And I want to encourage people that these are complicated issues, and it's challenging to work together to be able to make things better. And, yes, sometimes there are bad people, and sometimes we do find really bad things that happen, but a lot of other times, and just as often, it's just a difficult process and something that people want to have run as successfully as possible. So I really encourage all of you to let the facts be your guide as you go through and conduct oversight. So this is the big grid, and I wish I had more than 5 minutes, but I'll do my best. So to give an example, we have health equity and justice as a topic within Medicaid. And then once you give like that as your topic, I ask you to kind of just go a little bit deeper for me, just narrow it down to something. And so I chose Medicaid and reentry, and then put it into a factual question, something that will have like a real answer, but still keep it open-ended in case your investigation takes you a direction you might not expect. So the question I have is, how do returning citizens that qualify for Medicaid become covered? There was a kind of a nasty story about a year ago in a state where somebody was released from prison, qualified for Medicaid, and never got on Medicaid because he did not contact the right person in the right office to get on, went through his 30-day supply of medication, had been diagnosed with bipolar while in prison, tried to go see a doctor. Doctor said, I'll see you, but before you see me, get Medicaid. And he said, I thought I had Medicaid, and ended up being arrested for possession of illegal substance. So that really kind of inspired my interest in that as a question. And that's the kind of thing you could realistically think that could be in your news. That could be something that, you know, was discovered in your state. And then how do you go about getting the answers to, well, how do people, when they're returning from prison, get access to Medicaid if they're qualified? So going back to my avenues, maybe my auditor has some information on this. Maybe the budget, I can require reports on that topic. Maybe there's something in a committee, I can do a hearing, I can pull in the right people to get some questions answered. All those different steps along the way. In this case, it would probably be event driven if that was from the news. And then maybe this will take me 3 months to get a good answer, because you can't do everything all at once. You got to have a certain timeline of how long it'll take to be able to do what you're looking to do here. This is a big, intimidating slide. I will not go over all of it because I want Q&A, but this was the slide that we used back in September. And again, I used some feedback, and I appreciated there was an audience member there. And so I was able to add disability access, topic number 4 to this. So now I have 11. And this is not a complete list. In fact, what I would recommend if you're looking at this, just look at maybe 1 or 2 and then walk through this structure that's been built here at the State Oversight Academy and think through, okay, I really want to work on this one topic in this specific area inside of it. And then walk through all of it. Heck, send it my way. I'll read over it and I'll see if any other ways that I can help you kind of shape it and craft it and get ready to be able to think about the best way to move forward in your legislature. And with that, let's do some Q&A.
Ben, Ben, thank you so much. And I'll get back to my screen here. But as you can see, Ben's been doing some great work. And real quick, Ben, you've been going into some states too and doing some state specific work and even policy specific on oversight. Is that right?
That's correct. I've been able to testify in several states when they're looking to enhance their capacities through legislation or through interim studies. And I've also been able to do all day workshops on various topics and also half day. So yesterday I did a half a day in Delaware. Earlier this year, did a full day in North Carolina. It's been very encouraging. People want facts, and the legislature is uniquely positioned to be able to provide them. And I think a lot of times it's a gap from local news media not being quite as robust as it once was. And I think that if we're trying to find facts on Medicaid or on anything within our country today, a bipartisan inquiry with a bipartisan report is really about as strong as we can get. I really am encouraged by the progress that we're seeing all across the country on this.
Well, that dives into one of the questions that we got while you're speaking. So let me just get right to, there's a few here, but the first actually had to do with bipartisanship in terms of oversight. I think you said, and just to add on to this question that we got, you showed something from Michigan, but how frequently do legislatures, the question is there a way to kind of create bipartisan oversight committees that kind of are different than what you would see maybe a typical like partisan kind of makeup of a legislature that makes it more ensures the bipartisan makeup of ongoing oversight?
There's several great examples all across the country. So that joint resolution in Michigan, it would have created a bipartisan equal membership. And what was interesting about that was the start of the session, they were going to recommend to Michigan's Auditor General topics, things that they collectively agreed that they needed more facts and more information on. You're seeing that happen in California, for example. There was a bipartisan request from their legislature to their state auditor to do a comprehensive audit on the performance of homelessness programs. That was a bipartisan group saying we need information on what's working and what's not. And then also out in Idaho, they have a joint legislative oversight committee, JLOC, and they have some of the strongest contract oversight in the country. They had a horrible situation. They had a prisoner in a private prison who passed away from what could have been a routine medical situation. And so they developed this whole oversight committee. It's equal partisan membership. I mean, and that's a state that's pretty tilted one way in the parties, but they saw this need to have it be right down the middle and getting facts and information. And they've really focused in on these contracts that are high dollar, high risk, resembling probably some of the ways in which Medicaid is administered all across the country.
Great. And then the other question, Ben, and I think even the slide you showed about South Carolina maybe gave a hint of maybe how state legislatures could incorporate this, but it's about how do legislatures work with advocacy groups that do their own oversight? And how do you address the public concerns, engage the public in the design and accountability for Medicaid?
Oh, I'm so excited you asked that question. So yes, advocacy groups are an absolutely essential piece. They have to be at the table, and you have to be able to leverage that expertise, get the information, have that be a part of reports, have them be parts of the hearing, be able to really lean on that expertise and that information, because it also serves, at least for me in my previous experiences, it was a nice counter to the agency where I could really kind of cross-check what was being said between both of them. And it really helped me navigate my way to finding the truth of the matter. And so that's something that really stood out to me that's really been helpful throughout my experiences in conducting oversight, both in Michigan, now helping out across the country.
I think in that South Carolina examples, you had showed that they have this kind of formal process where they're always accepting input from either advocacy groups or just the public in general. Is that correct to say that?
That's correct. In fact, I can share the link with everybody after the fact. So they have it available online whenever you need it. And it's almost structured like a Google form, and they have this massive checklist of just about every agency you can think of that is within South Carolina state government. And then they have an other where if you just want to type in like, I'm just somebody that I want to know more about this very particular type of thing. I'm not sure which agency it might be housed in. And it's really resulted in some of their best oversight topics that they've looked into in that committee. And I mean, so their chief of staff is a good friend, and he's chief of 4. They have 5 people on that committee. So it's not like this big, massive, unwieldy committee at all. And what they're doing down there, it's pretty impressive. Given the product for just the amount of manpower or people power.
Yeah, that's a really good example, Ben. I want to open it up. We did have those questions that came in while is there anyone else that has some questions or would like to say anything about this issue of legislative oversight? Doesn't look like we have any other hands raised. So Ben, that was terrific, of course. And Robin, thank you again. So yeah, just again, I really just want to make sure that I emphasize how much we appreciate Robin and Ben for their insights and their knowledge and all the work they put into this. Really appreciate that, and appreciate everyone who joined us today. We've just gone over just a little bit an hour, but we've done pretty well. As Sean talked about at the beginning, just please keep CSG in mind as a resource on health policy, whether it's an individual research question you have, or if maybe we could potentially partner with you on some work you're doing in your state capitals to advance health policy. We are here to provide a resource and to help you. Last but not least, before I get off the call, I just want to wish everyone who's on here a very happy holiday season. And I hope to see you soon in 2024 in your capitals. Thank you so much to everybody. Appreciate it.
Thank you, everybody.